Sorry. Okay, I'll get started. Um, yes, I'm sorry not to be there, but very happy to connect virtually. Um, I've had the pleasure of working with Professor Sigambuzu for a number of years, alongside a few others in the team over there, and very excited about the potential of this new centre. I hope we can continue to build strong collaborations and achieve some ambitious goals. So today I've been asked to reflect on some of my work examining the economic issues affecting health workers globally, and also noting the presence of many much more esteemed thinkers than me in this area. I hope to highlight a couple of areas that I see potential for future work and hopefully some ongoing collaboration for all of us going forward. Um, we've heard a lot already about health workers, so I'll keep my background very brief and just focus on a few key and probably self-evident points. The first, I think, almost preemptively quotes Professor Joshi from this morning. Health systems are a lot more than just health workers, but without the health workers, there isn't much of a health system. The second point is that globally there's extensive resources invested in health workers. Estimates range from around 40 to 50% of total health expenditure is devoted to health workers and their salaries. And on top of that is the training and as we heard this morning, often their replacement and retraining. The final point is probably the crux of a lot of my work, which is that a lot of this investment does not seem to directly align with the goals of maximising population health or other health system objectives. There's a lot of examples of this, and I suspect everyone in the room and online could think of a couple. But I wanted to just draw on this idea and bring out some of the work that we have been doing, particularly around two areas, which are this idea, I think, that there's insufficient economic evidence guiding investment into programs that are led by perhaps non-doctor health workers, such as community health workers, as we heard from Tom and Rohina earlier. And I guess using economic evidence on that advocacy side that we discussed this morning to sort of generate a case for investment in those programs. On top of that, I think there's some shortcomings in policy that restricts the effectiveness of respond to complex problems that I think has led to decades of investment in programs that have minimal or at least unclear impact. And I'll give a couple of examples of work we've done in that regard. So under this first point, I think probably the key point is to just this idea that there's a variety of health workers, and I think health systems of all incomes need to ensure that they're making the most out of the available workforce that they do have. Investments often biased, I think, towards doctor-led later stage care and interventions. I think often at the expense of more cost-effective alternatives. This picture on the right is some modelling that I did based in Nigeria, and it's looking at maternal and child health outcomes across the country over the next 10 years. I won't go into the details, but basically these bars show the numbers of deaths that could be avoided. So in other words, the numbers of lives saved. And so over the 10 years, there was up to 4 million mothers and kids, basically, deaths that could be averted through a package of quite simple interventions. And 95% of the workforce that we modelled needed to deliver these interventions are non-doctors. So they were community health workers, nurses, midwives, and others along those lines. But investment available resources in Nigeria that are being spent on healthcare tend to be dramatically aimed at doctors still and later stage care. So we have sort of a few studies in this area. A lot of it is around economic evaluations. What an economic evaluation essentially is, for those in the room who might not be familiar, basically they try and determine the relative costs and benefits of investment in different policy options. So to work out which policy or intervention is the best to invest in, we basically just compare the different outcomes and try and convert this down to a comparable level. As a whole, these economic evaluations tend to demonstrate that in many situations, that when properly supported and supervised, many interventions led by non-physicians or similarly non-specialist doctors can be cost-effective alternatives to normal care, to doctor-led care, fill service or personnel gaps and even better meet patient needs. And just to note that this has been found across countries of all different income levels. So one example is just building on the results that Tom was speaking about this morning. I won't go into the detail, but this is the cost effectiveness analysis results for the initial trial that Tom went into this morning about the smart health intervention. As he mentioned, we found the intervention to be highly cost effective relative to usual care patterns, according to usual thresholds and usual measures of cost effectiveness, and considering Indonesia's relative income. So this evidence, I think, was an important part of the this economic results was an important part of the evidence base that sort of led to that next stage of local investment and the scale up project that's still going on and that Tom went through this morning. So community health worker programs, as Rahina mentioned, are far more common in low and middle income countries, but I guess the force to appropriately manage different types of care is an issue that affects countries of all income levels. So, for example, in Australia, we've done a number of studies, and this is one example. Again, I don't have time to go into the details, but this was an example where the care for chronic eye diseases, glaucoma and diabetic retinopathy, it's usually managed by an ophthalmologist, so a specialist within a hospital. The accessing care was a huge problem. There were wait lists of over a year to get an appointment. The intervention transferred a lot of the routine monitoring and care provision to rather than ophthalmologists. And so what we found were dramatically reduced wait times, as you can probably imagine, better attendance of patients, and also quite significant cost savings for each person. So the point here is just to point out that it is a universal issue affecting countries of all income levels. The next part of research I'd like to go into is this idea that cost effectiveness is great, and building an economic evidence base to support investment in these cost effective models of care is an important tool to guide health investments. But there are a range of system issues, as you all know, that can undermine healthcare access, quality, and effectiveness. So some of these issues that we've been looking at include health system corruption, as Rahina mentioned, the motivation, retention, and training of health workers, as well as
the incentives facing health workers because of different financing models. All of these things can have significant impacts on the care that is ultimately accessed and provided to the population. This example, this picture on the right, sorry, is an example of what we call a discrete choice experiment, which is a technique that we have used quite often. This piece of work was actually also led by Tom, presented this morning. What a discrete choice experiment does is, in situations where a trial isn't possible, we try and replicate the types of factors that are driving behaviour, the types of decisions being made by people, in this case health workers, using a survey, and ask them to respond to a series of questions like these, where in this case they were asked to pick between two potential jobs, and the jobs differ on the basis of key attributes that we've established are the main drivers of behaviour. So we've used this technique quite a lot, in particular to look at both the motivation and retention of most important factors that community health workers and others see in their job, but we've also, as well as using it in the corruption space, which I will provide a couple of examples of now. So health worker corruption is sort of an issue that's been seen as essentially unsolvable for many years. There's a long history of attempted interventions that have had essentially little or no impact in a lot of settings. Corruption affects health systems across all income levels and incorporates a range of behaviours, including of health workers, which includes things such as informal payments, where patients are charged additional fees, or fees for care that should be provided free of charge at the point of care, and health worker absenteeism, where health workers are paid to be at work but aren't, essentially. So traditionally, health worker corruption has been seen through this moral lens, where it's sort of a moral failing that it's some sort of deficiency in the health worker, where they're taking advantage of a system, and so the fixes for this have been traditionally more stringent and harsher penalties for infractions. Our findings and also the history of ineffective interventions over recent decades suggests that the story is a bit more complicated than this. And actually, many of the drivers of corrupt behaviours are things that probably most or many people will consider to be quite reasonable reasons, explanations for missing work, for example. So under program of research, we've undertaken several studies in Nigeria, Tanzania, and Bangladesh, with a couple of further countries being studied now. And what we were looking to do is basically identify the key drivers of these corrupt behaviours and see whether there was any space to potentially intervene to realign the incentives that are driving these behaviours, better align up with health system goals, such as provision of health care. Across all these studies, there are a few general findings that we can pull out. Corruption, specifically in this case, informal payments and absenteeism, was very common across the study countries. In each country, there were groups of people who could deliberately break the rules and escape sanction. So that this is sort of the traditional view of corruption. There definitely were people that were taking advantage of the system. There were also a large proportion of infractions were just related to context-specific issues. It's probably a good path to payments as a means to actually fund the care in situations where care wasn't properly funded, or payment was delayed, or even supplies weren't able to be paid for. So informal payments were then levied, or if people weren't able, there were no supplies at work, so there was sort of no point going to work, or there were huge rates of violence and abuse facing health workers, which sort of led to people staying away from work. The local networks of health workers were strong drivers of behaviour, and that this sort of worked in two ways. In some ways, it facilitated corruption in that people could get away with breaking the rules without fear of punishment. But also in areas where there were strong connections with local policymakers, there was lower corruption, and the impact of local monitoring seemed to be much greater than a higher level monitoring and punishments. So